Welcome to Last Minute Lecture. This free chapter overview is designed to help students review and understand key concepts. These summaries supplement, not replace, the original textbook and may not be redistributed or resold. For complete coverage, always consult the official text.
Welcome back to the deep dive. Today isn't just another discussion. I really want you to consider this your survival guide.
Yeah, that's a good way to put it. A survival guide.
We are turning the page to Chapter 35 of Pharmacology, a patient-centered nursing process approach. This is the 12th edition. And if you are a nursing student, or honestly just anyone trying to wrap your head around oncology, you know that this chapter...
The anticancer drugs chapter?
Right, the anticancer drugs chapter. It is an absolute beast.
It is incredibly dense. It's one of those chapters where every single sentence feels like it could be a test question.
Exactly. So our mission today is pretty specific. We aren't just chatting about cancer loosely. We are going to translate this dense textbook material into a survivable, understandable audio guide for you.
I like that mission.
We're going to walk through the chapter sequentially, just like you would if you were reading it, but we're going to pull out the bold print, the red flags, and the absolute must-know facts for your exams and for clinical practice.
And just to set the ground rules early for everyone listening, we are staying strictly within the text of Chapter 35.
Right, which is important to note.
Very important. Because, oncology is a field that changes daily. There are always new protocols and new clinical trials. But for the purpose of your exams and your foundational understanding, we are sticking to the book's gospel.
No outside protocol.
Exactly. No outside drugs, no alternative clinical practices, just what is printed on these specific pages. We want to make sure you have the exact knowledge required for this specific material.
Pure, undiluted textbook knowledge. I've always thought of chemotherapy as this complex battle strategy. You're the general, the nurses are the frontline tacticians, and the drugs are the weaponry.
That's a very accurate analogy, and Chapter 35 leans into that heavily.
But before we get to the weapons, we have to understand the enemy. And the chapter starts with this big picture, the overview of cancer.
It does. And it starts with some really sobering statistics right out of the gate. Cancer is the second leading cause of death in the United States, right behind heart disease.
Right.
And while the text does point out that mortality rates have dipped since the 1990s, it projects that nearly 40% of the population will develop cancer at some point in their lifetime.
That is just a staggering number to me. 40%. I mean, that's essentially a coin flip for almost half the room.
It is. And the text highlights that this doesn't hit everyone equally either.
Right. There are disparities mentioned in the book.
Significant disparities. For instance, the text notes that African Americans generally have higher mortality rates than any other racial or ethnic group. And then you have very specific variances, like Asian and Pacific Islanders having much higher rates of liver and stomach cancers.
And the book actually gives a reason for that specific statistic, doesn't it? It's not just random genetic bad luck.
No, it's not random at all. The textbook links those higher rates of liver and stomach cancers in Asian and Pacific Islander populations, specifically to higher incidences of hepatitis B and H. pylori infections.
Which is fascinating.
It is, because it really highlights how environment and infection history play a massive role in cancer development. It's rarely just one thing. It's a collision of factors.
So let's define the enemy for the listeners. What exactly is cancer, biologically speaking, according to this chapter?
At its absolute core, the text defines cancer as unregulated cell growth. It's abnormal cells growing completely out of control. And it emphasizes that this usually stems from damage to the DNA.
So it's fundamentally a genetic issue.
Yes. But it's not just one thing going wrong. It's not like you wake up one day, one single gene flips, and suddenly you have a tumor.
Right. It's a multi-step process.
Exactly. The book explains it essentially like a failure of checks and balances within the cell. You have these things called proto-oncogenes. In a healthy body, these are the good guys. They regulate normal cell growth and division.
But if they mutate?
If they mutate, they become oncogenes.
Oncogenes. So that's essentially the gas pedal getting stuck.
That is the perfect way to visualize it.
Yeah.
The gas pedal's stuck, so the cell starts dividing when it shouldn't be. But usually you have a backup system, the tumor suppressor genes.
And those are the brakes.
Think of those as the brakes, yes. They signal the cell to stop multiplying or even to self-destruct if things go too wrong.
So cancer happens when the gas gets stuck and the brakes fail at the same time?
Precisely. And because it takes multiple mutations For all of those intricate systems to fail, that's why age is such a huge factor.
Because it takes time for those errors to accumulate.
Exactly. The text explains that this is why we see higher cancer rates as people get older. The safety mechanisms have just had more time to wear down and accumulate DNA damage.
Now, there's a specific box in the text, box 35.1, that lists the risk factors. We mentioned infection a minute ago, but let's break that down for the students listening.
Infection is a major category. The text links HPV explicitly to cervical cancer. It links H. pylori, like we mentioned, to gastric cancer. And hepatitis B and C are listed as major drivers for liver cancer.
So these are essentially viruses and bacteria hacking our DNA.
That's exactly what they're doing. They alter the cellular environment.
And then there's the environmental category.
The massive one there is tobacco. The CDC stats included in the chapter note that 80 to 90% of lung cancers are due to smoking.
80 to 90%, that's huge.
It is. But the box also lists UV rays for skin cancer and asbestos exposure for lung cancer.
And what about diet? The book mentions diet too, right?
It does, and diet plays a surprisingly large role, according to the text. It warns against high animal fat intake and excessive alcohol, but it specifically calls out something called heterocyclic amines.
Heterocyclic amines, that sounds terrifying. What are those?
It's a chemical compound found in smoked meats.
Oh, what?
Yeah. So unfortunately, that barbecue might come with a warning label, according to Chapter 35. It's basically telling us that the process of charring and smoking meat creates compounds that can directly damage DNA over time.
Okay, so we know what cancer is, and we know where it comes from based on the text. Now, to understand how the drugs actually work, the book says we have to understand the biological battlefield, specifically the cell cycle.
This is absolutely non-negotiable for students.
Yeah.
You cannot understand pharmacology in oncology without deeply understanding the cell cycle. The text breaks it down into 5 phases. If you don't grasp this clock, the rest of the chapter just won't make sense.
Okay, let's look at the clock then. Walk us through the life of a cell.
Imagine a circle. We start the G1 phase. This is the setup phase. The cell is actively producing RNA and enzymes. It's getting all its materials ready.
Getting ready to do what?
To synthesize DNA, which brings us to the S phase. S stands for synthesis. This is where the cell is actually copying its DNA.
And I'm guessing that S phase is a prime target for these drugs.
A huge target. We'll see later that an entire class of drugs specifically attacks only during this S phase.
Okay, so after S phase.
After S, you have G2, which is another growth and preparation phase. And finally, you hit the M phase, mitosis. This is where the cell actually splits and divides into 2 identical daughter cells.
But there's a 5th phase the book talks about, right? One that isn't really on the active ticking clock.
Yes, G0, the resting phase. This is crucial because this is where the cell is just sitting there. It's alive, but it's not actively dividing or preparing to divide. And this G0 phase is the biggest hurdle in all of chemotherapy.
Why is a resting cell such a problem?
Because the vast majority of chemotherapy drugs work by attacking cells that are doing something. Cells that are dividing or synthesizing DNA or making enzymes.
So if a cell's just hiding in G0,
The drugs often just walk right past it. They don't see it as a target because the cell isn't performing the actions the drug is designed to interrupt.
that distinction naturally leads us to the 2 big categories of drugs the book defines. CCNS and CCS. Let's define this for everyone.
Right. CCNS stands for cell cycle-nonspecific. These are your heavy hitters. They can kill a cancer cell during any phase of the cell cycle, even to some extent while it's in the resting G0 phase, though the text notes they're still most effective on rapidly dividing cells.
So they're kind of like a carpet bomb.
In a way, yes. The alkylating drugs we'll talk about later fall into this CCNS category.
In the other category?
CCS, cell cycle-specific drugs. These are the snipers. They only work if the cancer cell is in a very specific phase of the cycle, like the S phase for synthesis or the M phase for mitosis.
So if you give an S phase specific drug, but the tumor cell happens to be in G1,
it won't work. The cell survives. That is exactly why timing, scheduling, and repeated dosing are so vital in oncology.
this also brings up a concept the text calls growth fraction.
Yes, growth fraction.
What exactly is that?
Growth fraction is simply the percentage of cancer cells within a tumor that are actively dividing at any given time. A high growth fraction means lots of cells are actively moving through the cycle.
So like a blood cancer, like leukemia.
Exactly. Leukemia has a very high growth fraction, so chemotherapy works very well against it because there are millions of active targets for the drugs to hit.
But what about solid tumors, like a breast tumor or a colon tumor?
Solid tumors are much trickier. As they get bigger, The core of the tumor often loses its blood supply, and those core cells go into that G0 resting phase, so they have a low growth fraction.
Which makes them way harder to kill with chemo alone.
Correct. The text also mentions that solid tumors have vascularization issues, meaning they have poor blood supply in the middle, which means we can't even get the drug delivered to those resting cells effectively. They're essentially hiding in a bunker.
Okay, so moving to the section on general principles of chemotherapy. The book talks about how we actually administer these drugs. I noticed it explicitly says single drug therapy is rarely used. Why is that?
It introduces the concept of combination chemotherapy. The text outlines 3 main reasons why we combine drugs.
Let's hear them.
First, synergy. The idea that 1 + 1 = 3. Using 2 or more drugs together often kills exponentially more cancer cells than the sum of them used separately.
Makes sense.
Second, to prevent drug resistance. Cancer cells mutate very rapidly. If you hit them with just one drug, they might figure out a way to survive it. But if you hit them with 3 different mechanisms of action at once, it's much harder for the cell to adapt.
And the third reason?
To attack the cells at different phases of the cell cycle simultaneously. You might use a CCNS drug to hit everything generally, and then add a CCS drug to specifically target the ones trying to divide. The text mentions protocols like CHOP or VAC.
CHOP and VAC, those are acronyms, right?
Yes, they're acronyms for specific combinations of chemotherapy drugs used in standard protocols.
We also see some specific terms regarding when we give the chemo relative to surgery. Adjuvant and neoadjuvant. I know nursing students always mix these two up.
It's a classic mix-up. The easiest way to remember it is to think of neo as meaning new or first. Neoadjuvant therapy is chemotherapy given before surgery.
So the goal there is to shrink the tumor down first.
Exactly. You shrink it down so the surgeon has a much easier time completely removing it.
So neoadjuvant shrinks it first. And adjuvant?
Adjuvant is given after surgery. The surgeon has already removed the visible tumor, but we know there might be microscopic cancer cells floating around in the blood or lymph. Adjuvant chemo acts as the cleanup crew to kill those invisible leftovers.
And then there's palliative chemotherapy.
Palliative means we aren't looking for a cure anymore. The disease is too advanced. In this case, we're using chemo to shrink tumors just enough to relieve pain or improve the patient's quality of life, but we aren't expecting to eradicate the disease.
The text also mentions a very specific delivery method called liposomal chemotherapy. What is the benefit of wrapping a chemotherapy drug in fat?
It's a really clever technology. It's basically packaging the active drug molecule inside a synthetic fat globule, or liposome. The book explains that this helps the drug stay in the system longer without breaking down.
But there's a safety benefit too, right?
A huge safety benefit. It crucially reduces specific side effects. The fatty liposome keeps the drug from leaking out into healthy tissues as easily, which can significantly reduce targeted toxicities, like heart damage, which we'll talk about with certain drugs later.
Speaking of toxicities, let's talk about the cost of war. Table 35.2 in the text is absolutely massive. It lists all the general side effects of these drugs. And the underlying concept here is that chemo can't tell the difference between a cancer cell and a healthy cell, right?
Right. Remember, traditional chemo targets rapid cell growth. Period. So any healthy cell in your body that naturally grows and divides fast is going to get caught in the crossfire.
And what are those healthy cells?
Primarily your hair follicles, the lining of your entire gastrointestinal tract, and most importantly, your bone marrow.
Let's start with the bone marrow, because the book calls this myelosuppression, and it seems like a massive focus.
This is probably the single most critical safety concept for a nurse to grasp in this chapter. Your bone marrow is the factory that makes your red blood cells, your white blood cells, and your platelets. Chemotherapy essentially shuts down that factory.
So if your red blood cells drop, you get anemia.
Right.
Which means fatigue, hypoxia, shortness of breath. That makes logical sense. But the white blood cells dropping, that's the truly scary part.
Yes. Neutropenia, dangerously low white blood cells. This leaves the patient entirely defenseless against infection. And the text introduces a vital vocabulary word here. The nadir.
The nadir, N-A-D-I-R. Define that for us.
The nadir is the exact point in time after the chemotherapy dose when the patient's blood counts are at their absolute lowest.
When does that happen?
According to the text, this typically occurs 7 to 10 days after the treatment is administered.
So a patient might get their infusion, go home, feel okay for a few days, but a week later,
they are in the danger zone. They have virtually no immune system. And there is a specific number every single nursing student needs to memorize from this chapter.
What is it?
If a patient on chemotherapy has a temperature greater than 101 degrees Fahrenheit.
Or 38.3 degrees Celsius?
Yes. 101 Fahrenheit or 38.3 Celsius. If they hit that,
that's a medical emergency.
It is an absolute drop everything emergency. Because they have no white blood cells, a low-grade fever is often the only sign you might get that full-blown septic shock is setting in.
Because they can't create the normal signs of infection.
Exactly. They won't have pus, they won't have major swelling or redness because they simply don't have the white blood cells to create that inflammatory reaction. You have to report that temperature immediately.
Okay, so that's white and red cells. What about platelets? The book calls this thrombocytopenia.
Low platelets mean a severe risk of bleeding. The text advises nurses to strictly avoid invasive procedures. No intramuscular injections if you can possibly help it.
And what are we assessing for?
You need to look closely for petechia.
Those are the little red pinpoint spots on the skin, right?
Right. It indicates microbleeding under the skin.
Mm-hmm.
Also check for bleeding gums or blood in the urine or stool.
Moving on from the bone marrow to the GI tract. Nausea and vomiting are the classic chemo side effects everyone knows.
The text notes this is caused by direct stimulation of the chemoreceptor trigger zone in the brain. It's not just an upset stomach, it's a direct chemical signal in the brain telling the body to throw up.
So how do nurses manage that?
The key nursing action emphasized in the text is pre-medication.
Pre-medication.
Yes. Don't wait for the patient to throw up. You must give the antiemetic drugs before the chemotherapy infusion even starts.
The text also mentions mucositis or stomatitis, mouth sores.
These can be incredibly painful. It makes eating and drinking very difficult, which leads to weight loss and dehydration.
What's the nursing intervention there?
The text recommends teaching the patient to use soft bristled toothbrushes and strictly avoiding any commercial mouthwashes that contain alcohol.
Because the alcohol would burn.
It would burn like crazy on open sores. They need gentle saline rinses instead.
Then there's alopecia, hair loss.
This impacts the patient's body image heavily. It's devastating for many. The text strongly suggests discussing options like wigs or scalp cooling caps before the hair loss actually happens, so the patient is mentally and practically prepared.
And finally, for the general side effects, the reproductive system.
Infertility is a very real, very permanent risk. The nursing advice is to advise patients to look into banking sperm or freezing eggs before the treatment begins, because there are absolutely no guarantees reproductive function will ever return.
Okay, we have the landscape. Now let's open the armory and look at the actual weapons. The text breaks the drugs down into distinct classes. Let's start with class 1, the alkylating drugs. I like to call these the bashers.
The bashers, that's aptly named. These drugs literally damage the DNA by cross-linking the strands.
Cross-linking, what does that look like?
Imagine taking the two sides of the DNA double helix and supergluing them together. When the cell tries to pull them apart to replicate, it can't. The DNA breaks and the cell dies.
And these are CCNS, right?
Yes. Cell, cycle-nonspecific. They will bash that DNA regardless of what phase the cell is in.
And the prototype drug the book highlights here is cyclophosphamide, also known as cytoxin.
Cyclophosphamide is an absolute workhorse in oncology. It's used for lymphomas, breast cancer, leukemia.
But it has a very specific, very nasty adverse effect that shows up on every single nursing exam.
Hemorrhagic cystitis.
A bleeding bladder.
Exactly. As the body breaks down cyclophosphamide, it produces toxic metabolites. These metabolites travel to the bladder and literally sit there, chewing up the bladder lining and causing severe bleeding.
So how do we as nurses prevent that from happening?
The text gives two clear interventions. First, massive hydration. The patient needs to drink at least 2 liters of fluid a day and empty their bladder frequently, especially at night, to keep flushing those toxins out.
And the second intervention?
A specific rescue drug called Mesna.
Mesna, M-E-S-N-A.
Yes, Mesna is a chemoprotectant. It chemically binds to those toxic metabolites while they're in the bladder and neutralizes them before they can cause damage. So if you see an order for high-dose cyclophosphamide, you should fully expect to see an order for Mesna hanging right next to it.
Also, the text gives a major warning that this drug is a severe vesicant.
It is. A vesicant means that if the IV line infiltrates and the drug leaks out of the vein and into the surrounding tissue, it causes severe tissue necrosis. It will eat the tissue. You have to watch that IV site like a hawk.
Under the same category of alkylating-like drugs, we have the platinum drugs, cisplatin and carboplatin.
Right. They work very similarly to the alkylating agents by cross-linking DNA.
What's the major distinction the book makes about them?
The expert note here is that while they are incredibly tough drugs with severe side effects like kidney damage, they carry a slightly lower risk of causing secondary leukemias later in life compared to the nitrogen mustards like cyclophosphamide.
Okay, moving on to drug class 2. The antimetabolites. I call these the imposters.
Imposters is a great way to think of them. They are structurally designed to look exactly like natural substances your body needs to survive. Things like folic acid or pyrimidines.
So the cancer cell invites them in.
It eagerly invites them in, thinking it's getting food to build DNA. But once the drug is inside, it jams up the machinery and disrupts DNA and RNA synthesis.
And because they specifically interfere with synthesis, I'm guessing they are.
S-phase specific, yes. They mostly only work when the cell is actively trying to copy its DNA.
The first prototype the book gives here is methotrexate.
Methotrexate is a classic folic acid antagonist. Cancer cells desperately need folic acid to build new DNA. Methotrexate stops them from using it.
But here's the problem. It stops healthy cells from using folic acid too, right?
Right, which leads to the absolute must-know protocol for this drug, the leucovorin rescue.
Okay, explain this carefully because I know students get this mixed up on exams all the time.
Okay, listen closely. You give the heavy dose of methotrexate to kill the cancer. But it's going to kill the patient's healthy cells too if you aren't careful because it's starving them of folic acid.
Right.
So 12 to 24 hours after the methotrexate infusion is finished, you give a drug called leucovorin.
What is leucovorin?
Leucovorin is a specialized form of active folic acid that bypasses the methotrexate block. The healthy cells can pick it up and use it to save themselves from dying.
So it's an antidote.
Essentially, yes. It rescues the normal cells. But the text gives a very bold warning here. Do not confuse leucovorin with regular over-the-counter folic acid. They are not the same thing.
And timing is everything.
Timing is everything. Do not give leucovorin at the exact same time as the methotrexate, or you just neutralize your chemotherapy. It has to be a rescue given afterwards.
Got it. Also, the text mentions a severe interaction with NSAIDs.
Yes. Taking regular aspirin or NSAIDs like ibuprofen while on methotrexate can cause severe, life-threatening toxicity. The NSAIDs interfere with the kidney's ability to clear the methotrexate, causing the drug levels in the blood to spike dangerously high.
The second prototype in this imposter class is fluorouracil, usually just called 5-FU.
5-FU. It's a pyrimidine analog. It's used a lot in gastrointestinal and colorectal cancers.
What is the specific toxicity we need to watch for with 5-FU?
Besides the usual severe bone marrow suppression and GI bleeding, 5-FU causes a very unique condition called hand and foot syndrome.
The textbook term for that is palmar-plantar erythrodysesthesia.
Yes, which are just fancy medical words for severe redness, swelling, peeling, and blistering pain on the palms of the hands and the soles of the feet.
That sounds debilitating.
It can be so painful the patient can't walk or hold a glass of water. As a nurse, you monitor their skin closely, and you also monitor their white blood cell counts. The text says to stop the drug immediately if a rapid drop in WBCs occurs.
Okay, let's look at drug class 3. Anti-tumor antibiotics. Now, we need to be clear, these aren't for treating a sinus infection or strep throat.
Definitely not. They are derived from strains of bacteria originally, which is why they technically fall under the antibiotic umbrella, but they're far, far too toxic to use as regular antibiotics for infections.
How do they work?
They interfere with enzymes involved in DNA and RNA synthesis. They are cell cycle-nonspecific, CCNS.
And the main prototype here is doxorubicin, or, as it is very famously known in the oncology world, the red devil.
The red devil. It is literally a vivid, bright red liquid in the IV bag.
But you have to warn the patient about that, right?
You absolutely must. You have to tell them, this is going to turn your urine pink or red for a day or two. It is completely harmless, but if they aren't expecting it, they will look in the toilet and think they're hemorrhaging to death.
But there is a danger with doxorubicin that is definitely not harmless.
Cardiotoxicity. This drug is famous for damaging the heart muscle. It can lead to severe, irreversible heart failure.
Irreversible?
Often, yes. That is exactly why there's a strict lifetime maximum cumulative dose limit for doxorubicin. Once a patient hits that specific lifetime limit, they can never, ever have the drug again, no matter what.
And is there a protectant drug for this one? Like we had Mesna for the bladder?
There is. The drug is called dexrazoxane. The trade name is Zenocard.
Dexrazoxane.
Yes. It can be given prophylactically to help protect the heart from the doxorubicin damage.
So Clinically, if your patient who is receiving doxorubicin starts complaining of shortness of breath, or you notice new edema in their legs,
you assume they are going into heart failure until proven otherwise. It is a major red flag. Also, the text explicitly notes that doxorubicin is absolutely contraindicated in patients who already have severe pre-existing heart issues.
Drug class 4, the plant alkaloids, nature's weapons. The book notes these are derived from things like periwinkle plants and yew trees.
Yes. These drugs act specifically by blocking cell division at the M phase, mitosis. They essentially freeze the cell while it's in the middle of trying to pull itself apart.
The prototype here is vincristine. And this one is fascinating because of what it actually doesn't do compared to the others.
Right. Vincristine is highly unique in this chapter because it is considered bone marrow sparing.
Bone marrow sparing, meaning it doesn't cause that massive drop in white blood cells?
Exactly. It doesn't wipe out the blood counts nearly as severely as almost every other drug we've talked about.
Okay, but this is chemo, so what's the catch?
The catch is the nerves. Vincristine is notorious for severe neurotoxicity.
Describe what that looks like for the patient.
It attacks the peripheral nervous system. Patients will develop numbness and tingling in what we call a stocking glove pattern.
Meaning their hands and feet.
Right, where you would wear gloves and stockings. They can also suffer a complete loss of deep tendon reflexes.
And the text also heavily emphasizes assessing their bowel movements. Why?
Because the drug affects the autonomic nerves in the gut, too. It can cause a paralytic ileus.
So the intestines just stop moving.
They completely stop. Severe constipation that can lead to an obstruction. So you have to monitor their bowel function and bowel sounds incredibly closely.
What happens if vincristine leaks out of the IV? Is it a vesicant?
It is a severe vesicant. If it infiltrates, it is a disaster. It causes horrible tissue necrosis.
How do you treat it if it leaks?
The text is specific here. You stop the infusion, leave the needle in place to attempt to aspirate any drug out, and then you treat the site with warm compresses and inject an antidote called hyaluronidase to help disperse the drug.
Warm compresses, not cold.
Warm. That's the key detail to remember.
Then we have another group of plant-derived drugs, the taxanes, like paclitaxel.
Derived from the bark of Pacific yew trees, these also affect the microtubules during cell division.
What's the big nursing consideration for the taxanes?
Severe allergic reactions. Hypersensitivity is so incredibly common with paclitaxel that you typically have to pre-medicate the patient heavily with corticosteroids and antihistamines before you even hang the bag.
Okay, let's completely shift gears to the hormones and hormonal agents. The book makes a point to say these aren't really cytotoxic in the same way traditional chemo is.
No, they aren't. They aren't going in and poisoning the cell's DNA directly. Instead, these agents work by either masking the cancer cells or blocking the specific hormones that the tumor relies on to grow.
We have corticosteroids listed here, like prednisone and dexamethasone.
Nurses are going to see prednisone everywhere. In cancer treatment, it's used to massively suppress inflammation, and it actually suppresses the immune system, which is helpful in certain leukemias and lymphomas.
But the side effects of high-dose steroids are significant.
Very. Severe insomnia, fluid retention leading to a moon face, mood swings, or roid rage.
And crucially, hyperglycemia.
High blood sugar.
Right. So if your cancer patient happens to also be diabetic,
you need to monitor their blood glucose meticulously while they are on these steroids, and they will likely need their insulin doses adjusted upward.
Then we have the sex hormone blockers. Tamoxifen is the big prototype for breast cancer.
Tamoxifen works by blocking the estrogen receptors on breast cancer cells. If the tumor needs estrogen to grow, tamoxifen starves it of that signal.
But because it's messing with the body's estrogen levels systemically, there are risks.
Yes. The text highlights that it increases the risk of developing uterine cancer down the line. And very importantly, it significantly increases the risk of blood clots, DVT, and pulmonary embolisms.
And what about for prostate cancer?
For prostate cancer, we use anti-androgens like bicalutamide to block testosterone from reaching the tumor. We also use aromatase inhibitors like anastrozole.
How do those work?
Anastrozole stops the body from converting other hormones into estrogen, which is used mainly in postmenopausal women with breast cancer.
The text also includes a section toward the end on miscellaneous and targeted therapies. It specifically mentions thalidomide.
Yes, thalidomide. It has a very dark history in medicine as a severe teratogen. It caused horrific birth defects when used for morning sickness decades ago.
But it found a new use.
It turns out it is highly effective as an immunomodulator for treating multiple myeloma.
But the safety protocols must be intense.
Incredibly strict. The text mentions specialized RMS programs. Absolutely no pregnancy allowed. Patients, prescribers, and pharmacies all have to be registered just to handle it.
And finally, vaccines. We aren't just treating cancer in this chapter, we're talking about preventing it.
Right. Preventive cancer vaccines. The hepatitis B vaccine essentially prevents the liver cancers associated with that virus. And the HPV vaccine, Gardasil, directly prevents cervical and genital cancers.
And there's an actual therapeutic vaccine mentioned too.
Sipuleucel-T.
That's a tough one to say.
It is. It's used for advanced prostate cancer. Instead of preventing the disease, it actually trains the patient's own immune system to recognize and attack the prostate cancer cells that are already there.
All right, that brings us to what might be the most practical part of the entire chapter for our listeners, the nursing process and clinical judgment, putting all this theory into safe practice.
Safety is the absolute headline here. These drugs are fundamentally toxic.
Review the concept of high alert medications for us.
Chemotherapy drugs are universally considered high alert. This means they have a very narrow therapeutic window and a high risk of causing catastrophic patient harm if administered incorrectly.
And there's a risk to the nurse, too.
A huge risk. These agents are mutagenic and carcinogenic themselves. Nurses must wear specific, specialized chemotherapy gloves and completely impermeable gowns.
You do not want this stuff touching your skin.
Never. You also have to use special biohazard containers for all the IV tubing and bodily fluids.
Okay, so before you even hang the chemo bag, what are the non-negotiable assessment priorities?
Baseline labs. You never ever give a dose of chemotherapy without checking the morning's complete blood count, or CBC, and the kidney and liver function panels.
So if you look at the chart and the platelets are dangerously low, or the white blood count has crashed.
You hold the drug, you stop, you do not hang the bag, and you call the oncologist immediately.
And what about assessing the physical IV site?
You assess it immediately and constantly. We just talked about vesicants like doxorubicin and vincristine. If those leak into the tissue, the patient can literally lose an arm. Prevention of extravasation is paramount. Ensure you have a brisk blood return before you start pushing the drug.
Patient teaching is another massive section here. We need to tell these patients how to actually live while taking these drugs.
Let's break it down by the side effects. For infection prevention due to neutropenia.
Teach them to avoid crowds.
Avoid crowds, absolutely. And importantly, no fresh-cut flowers in the room. And no unpeeled, fresh, raw fruits or vegetables.
Because they carry bacteria.
Yes. Soil and raw skin are covered in bacteria that a normal immune system fights off easily, but it could be lethal to a chemogenic. And again, teach them to report any fever over 101 immediately.
What about teaching for the bleeding risk? Thrombocytopenia.
Tell them to use an ultra-soft toothbrush only. And they must switch to an electric razor. No straight blades or safety razors that could nick the skin.
And
nutrition is tough because of the nausea. Teach them to eat small, frequent meals rather than 3 big ones. High-calorie, high-protein foods because their body needs the energy to repair the healthy tissue that the chemo is destroying.
What if they're actively nauseous?
Bland foods. Dry crackers, Kos. And if they develop chemo-induced diarrhea, teach them to strictly avoid spicy foods, heavily fibrous foods, or extreme hot or cold temperature foods, which can stimulate the bowel even more.
Okay, let's apply all of this. The chapter actually ends with a great case study that really tests your clinical judgment. Let's walk through it.
This is where we put the pieces together.
So the scenario from the book is a 43-year-old female patient with metastatic colorectal cancer. She is on a specific protocol of irinotecan, 5-FU, and leucovorin.
Okay, so we have a multi-drug protocol.
She comes into the clinic for round 3 of her treatment. Here's the assessment data the nurse gathers. Her temperature is 99.3 degrees Fahrenheit, and it's trending up from her baseline. Her heart rate is suddenly irregular. She is complaining of a new right upper quadrant abdominal pain, and she tells the nurse that her hands and feet feel extremely hot and tingly.
Okay, there are a lot of cues to unpack there. Let's take them one by one.
First, the temperature. 99.3 degrees. That is not the 101 degree emergency threshold we talked about earlier. Is it really a problem?
In a chemotherapy patient, yes. The text specifically flags this. It's trending up. You have to remember, her immune system is totally suppressed. She likely cannot mount a full high-grade fever, even if she has a severe infection.
So a low-grade fever is a major red flag for neutropenia.
Exactly. It's the smoke that tells you there might be a fire you can't see.
Next cue. The irregular heart rate.
She's on 5-FU and irinotecan. Now, while doxorubicin is the famous heart killer drug, 5-FU can also cause cardiotoxicity in some patients. An irregular heart rate in a patient on this protocol requires an ECG immediately.
The third cue is the right upper quadrant abdominal pain.
Think about your anatomy. What's in the right upper quadrant?
A liver.
The liver. And 5-FU is heavily metabolized by the liver. This sudden pain suggests acute liver toxicity or inflammation caused by the drug.
And the final cue, the hot, tingly hands and feet.
That is the absolute classic textbook presentation of hand and foot syndrome associated with 5-FU. It starts with that heat and tingling, and if you give the drug again, it will progress to severe peeling and blistering pain.
So, synthesizing all that data, what is the clinical conclusion?
The conclusion is that you absolutely do not give round 3 today.
You hold the drug?
You hold the drug. These are not normal expected side effects to just push through. These are signs of severe, potentially life-threatening toxicities. They require immediate nursing follow-up, lab work, and likely a dose adjustment or a complete delay in her treatment cycle.
This chapter really is intense, but when you break it down like this, the patterns definitely start to emerge.
They do. It's all about matching the specific toxicity to the specific drug's mechanism of action. Once you understand how the drug works, the side effects just make logical sense.
So as we wrap up, let's recap the big 3 specific drug toxicities that every student must remember from this chapter.
Okay, the big 3. Number 1, cyclophosphamide equals bladder. Remember hemorrhagic cystitis, forced fluids, and look for the rescue drug Mesna.
Number 2,
doxorubicin equals heart, the red devil. Check the ECG, watch closely for fluid overload or shortness of breath, and remember the lifetime dose limit.
And number 3,
vincristine equals nerves. It spares the bone marrow, but destroys the nerves. Check their sensation in their hands and feet, and constantly assess for constipation or a paralytic ileus.
And I'll add, don't ever forget the cell cycle.
Right. If you know where the drug works on that clock, you know how to schedule it. S-phase drugs are for rapidly synthesizing cells. CCNS drugs are for the generalized big hits.
And what's your final word on safety for the nurses listening?
Protect the patient from the world. Guard them against infection and bleeding. But also, protect yourself from the drugs. Always wear your proper PPE.
Take a deep breath, everyone. Pharmacology is incredibly tough, but it really is manageable when you find these patterns.
It is. Just remember, don't just be a pill pusher. Know exactly why you were giving a drug, know how it works, and know exactly what adverse effects you are looking for. That is what true clinical critical thinking is.
You know, it makes me wonder, reading through this chapter, if we are already developing therapeutic vaccines that train the immune system, maybe in 20 years, we won't even use these heavy CCNS drugs anymore. Maybe we'll just genetically map a tumor and program the body to clear it without ever dropping a single white blood cell. It's wild to think about where this text will be in the 30th edition.
It's a great thought. The science is moving exactly in that targeted direction.
Well, thank you for listening to this deep dive into Chapter 35. This has been the Last Minute Lecture Team.
Good luck with your studies. Keep reviewing those prototypes.